Good afternoon, everyone. My name is Eli Akel, and I'm a professor of medicine at the American University of Beirut in Lebanon. I have the pleasure to be moderating this very exciting session on health equity and systematic reviews. I would like first to welcome you all and thank you for joining this session. I would like to thank the organizing committee for the opportunity to be moderating the session. It's a real honor to be with two distinguished speakers, so Dr. Zulfikar Bhutta and Dr. Vivian Welch. The way this will work is that each one of our two speakers will present for 2 minutes, and then we'll have about 30 minutes at the end for a discussion and a Q&A session. Dr. Bhutta will discuss first the global social and health inequities as 19. Welch will discuss the pragmatic methods for assessing effects on equity in Campbell and Cochrane reviews. So let me start first by introducing Dr. Bhutta. He is a distinguished university professor and founding director of the Institute for Global Health and Development and the Center of Excellence in Women and Child Health at the Aga Khan University. He also holds the Robert Harding Inaugural Chair in Global Child Health at the Hospital for Sick Children, Toronto, and the co-director of the Sick Kids Center for Global Child Health, a unique joint appointments. He also holds adjunct professorship at several leading universities on a global level. He is a designated distinguished national professor of the government of Pakistan and was the founding chair of the National Research Ethics Committee of the government of Pakistan from 2003 till 2014. As you might have seen on his biography, he has been a member of a number of high-level global committees and experts groups with the United Nations, World Health Organization, etc. So it's a pleasure to have you, Dr. Bhutta, with us. The floor is yours.
Thank you very much, Ali, and delighted to be a part of this virtual Cochrane Symposium. Perhaps I can have the slides on. So I'm presenting this on behalf of a fairly large group in my research program here in Toronto and in Pakistan, who've been looking at COVID-19 from the very outset from a variety of lenses, looking at epidemiology, but also importantly on the consequences and some of the indirect effects of the pandemic on particularly women and children and families. So this has indeed been called a syndemic. The COVID-19 phenomena worldwide has exacerbated existing disparities and has also highlighted the interconnection between various conditions, particularly non-communicable diseases, social conditions, and health outcomes. As you can see from this graphic, these are all intertwined, but we usually do not recognize them until something happens that exacerbates the consequences of that nexus. So from a very early part of the pandemic, it was apparent that it wasn't hitting all parts of the world, indeed not all sections of society in many countries equally. In the United States, it's been very clear that there's been a racial gradient, that the rates of deaths due to COVID-19 here in this particular slide is per 100,000 population, are significantly higher amongst the Black or African American populations. And then as you see, there's a gradient with rates in even Hispanics and Latinos or other entities being much higher. So these are reflective to a large extent on some of the social gradients that you see in people who are exposed differently to the risks of the pandemic. Elsewhere, these are data from United Kingdom, from England, from an earlier stage of the pandemic last year, where you see that the gradients that you see across various sections of the population based on deprivation are notable not only for COVID-19, but also for other conditions. And this gives you all-cause mortalities, age standardized, and also for COVID and non-COVID-19. But for COVID-19, you will see that the most deprived sections of the society had higher rates of COVID-19 mortality. Here in Canada, we have been very well aware of these disparities from an early stage, and you will see in this particular slide, this is reflected by a different measure. This is reflected by the diversity and quintiles based on ethnicity. So populations which are very ethnically diverse have approximately 3 times higher COVID-19 incidence than those that are least diverse, and these have been notable in terms of also the predominance of not only disease itself, but also hospitalization rates. You also notice this across Canada in the prevalence of COVID-19 mortality in various ethno-cultural neighborhoods. Here, if you had greater than 25% diverse population in a given neighborhood, you can see for yourself as to how COVID-19 mortality rates have been significantly higher. So those disparities have been quite a notable part of this current pandemic, and for good reason, because the reasons for this are largely related to various forms of social deprivations and determinants that we recognize. It is not just in high-income countries. Even when you go to low-income countries, reflected in this particular map of Brazil, you find that these geographic disparities that you see in much higher rates of COVID-19 mortality reflect to a large extent also social demographic factors that predispose certain populations to much greater risk and adverse outcomes. So these vulnerable groups, ladies and gentlemen, are disproportionately affected by COVID-19 because, firstly, their risk of infection may be much greater. Some of these essential workers have no option. Very few of these ethnic minorities have had the option of being able to work from home safely. The second, the existing social inequalities already have higher proportion of non-communicable diseases that we know increase the risk of adverse outcomes in COVID-19. So the preponderance of many of the risk factors have been much greater, as well as their access to healthcare services may be limited. And that these risks of social deprivations not only compound the direct effects of infection, but also their predisposition to indirect effects. And the indirect effects have been of particular interest in terms of the disease, the mitigation strategies that were put in place, things like lockdowns and other restrictions. And they've been also different in different parts of the world. So these are some of the economic impacts of various mitigation strategies, particularly lockdowns and inability for daily wage laborers to work in communities where they have no recourse to add to their family income because of the absence of any social protection. And you will see that across various geographies, the ILO estimates that about 9% of the global workforce was lost in terms of their ability to earn a daily wage. And that's been quite remarkable. In some parts of the world, like India, for example, from a very early outset, the imposition of lockdowns led to mass migration from urban to rural population, maybe one factor in the spread of COVID-19 to many rural areas. Some of the indirect effects are related to health service disruption. And this has been particularly notable for women and children because of the loss of essential services like immunizations, access to antenatal care. And this has been quite remarkable in many populations where people do not have access to also telehealth and any of the other services. And WHO has been looking at a range of these pulse surveys in terms of disruption, and disruptions have been different in different quarters. On the right side of this graphic are the proportion of countries that have been affected by at least one disruption. And you'll find that in some geographies, there have been up to at least half of all countries have reported disruptions. Again, not restricted to any particular region, but there are things that we don't have good data on. And for some countries, we have data on things like intimate partner violence in this particular graphic from Peru, which increased significantly because of the lockdowns and the fact that families could not go anywhere. Rates of divorce in many populations or splitting of partners have also gone up significantly because of the impact of mitigation strategies. We've looked at this in depth in South Asia, both through actual district health information system data. This is a report that was just published from my group a month ago, looking at the entire South Asia region in terms of its impact, the impact of these COVID mitigation strategies on health outcomes. And to cut a long story short, the impact has been remarkable, has been quite significant, with close to around an 11 to 12% increase in child and maternal mortality over this period. And they're based on actual DHIS data from district health systems. And there are things that we don't talk about, which we do not have a good handle on, what has happened to adolescents, unintended pregnancies, and girls who have dropped out of school because of school closures. But currently, the greatest inequity that we are facing worldwide is in our immunization response. So these are data which are already old now. They are from a few days ago, where of the 700 million COVID-19 vaccine doses that have been administered across the world, 193 countries, 27 countries have not even begun to vaccinate. And you can see from this color coding that in many countries, the proportion of people who have had access to a vaccination have been very small. And this difference is very striking when you translate that into low, middle income and low income settings. So in low income settings, 160 times fewer doses of COVID-19 vaccine, despite the COVAX, have been made available. And this is a remarkable travesty, a disparity, as Tedros, Dr. Tedros, the Director General of WHO, has said repeatedly, that history will never forgive us on, because of our inability to be able to roll out a fundamental health intervention. So to summarize, therefore, ladies and gentlemen, COVID-19 has deepened existing inequities. They were already there. They've been exacerbated by this pandemic, and a range of things have happened because of the increased vulnerability of populations due to poverty, the difficulty in certain subsections of the population to adhere to lockdown measures because their livelihoods depended upon it, restricted access to services, disruption, particularly on maternal child health and nutrition interventions, and also by diversion of resources. The COVID-19 response in many countries has absolutely drained any extra capacity from the health system and has led to quite a significant financial burden. And this financial hardship, particularly in societies, is also going to have consequences in times to come. As we move forward, why these data are important is because we can act on them. And the acting on them can be at the level of national efforts, by focusing attention on who are the marginalized, where do people live, as you saw in the map from Brazil, which are the sectors, the Manas area, where you need to put a lot more resources and efforts. Also on getting better data. The eye does not see what the mind does not know. Even now, as I speak to you, the populations of the world where we have least data on COVID-19 are the conflict-affected populations, displaced populations. The rates of testing are very low, so people think mistakenly that there is no disease there. So these are things that we need to address with some alacrity if we're going to have some global justice. And finally, I think we need to do something about global COVAX strategy, because COVAX, at this time, with virtually no vaccines coming into the pipeline, is almost dead in water. And unless we do something about it, many countries may not have access to vaccines well into next year. Thank you very much for your attention, and I'll be happy to take questions in our panel.
Thank you so much. That was a very insightful presentation. It seems that we've just seen the tip of the iceberg so far. But thank you again. So now we move to the next presentation by Dr. Vivian Welch. So this presentation will be a recorded presentation, but as you can see, Vivian is with us today. So as a brief presentation, Dr. Welch is the editor-in-chief of the Campbell Collaboration. She's the director of the Methods Center at the Bruyère Research Institute in Ottawa, and an associate professor at the University of Ottawa School of Epidemiology and Public Health. She co-convenes the Campbell and Cochrane Equity Methods Group and led a new chapter on assessing health equity in the revised Cochrane Handbook, which was published in 2019. So Dr. Welch has a distinguished research career. She was awarded a recognition as one of the top 100 women in global health in 2018, the Lancet and Canadian Society for International Health, and an Ontario Early Research Award. Vivian, it's a pleasure to have you with us. I guess we'll move to the recording now.
All right. Okay. Well, thank you very much for having me here at Virtually Cochrane. I'm Vivian Welch, Editor-in-Chief at the Campbell Collaboration, scientist at Briere Research Institute, and Associate Professor, School of Epidemiology and Public Health, University of Ottawa. And I'm going to give a very brief overview of the methods for considering equity in your systematic review based on the Cochrane Handbook chapter. So I will just advance. I just want to first acknowledge that I live and work on the unceded territory of the Algonquin and Anishinaabe Nation. And as declarations of interest are the various positions I hold with the Campbell Collaboration and the Cochrane Collaboration as co-convener of the Campbell and Cochrane Equity Methods Group. And I hold funding from Canadian Institutes of Health Research, the WHO, and NIHR, not for this work that I'm about to describe. So when we're thinking about equity in reviews, I know this talk is coming after Zulfi Bhutta, who has described the importance of thinking about equity. In systematic reviews, we may have systematic review questions which are wholly focused on equity questions, or you may have more universal questions where there are equity concerns about distribution of effects, for example, vaccination. And one of the things we did thinking about equity in policies was this framework that we published last year on thinking about equity harms with COVID-19 lockdown policies. Often when we're doing systematic reviews, we're focused on the effectiveness of an intervention, and we sometimes don't think about the adverse effects, but inequities may be adverse effects of some policies that have intended positive effects. So these are some examples across different aspects of equity where there may be harms for certain social groups. So for example, place of residence, closing green spaces might cause more crowding for people who are homeless, and there are effective interventions to address them. We also looked at the same framework and applied it to low middle income countries where the context is different. And these are things that might be relevant for your systematic reviews to consider. So when thinking about equity in your reviews, we wanted to highlight that there's now a chapter in the Cochrane Handbook that can support you in thinking about this. The chapter is a starting point. There is also Cochrane training available on equity. And when thinking about this Cochrane Handbook chapter, there is already one standard in the methodological expectations and conduct standards to think about issues of equity, whether they're important for the review, plan for appropriate methods to address them, such as those relating to participant groups, like low socioeconomic groups, low middle income countries, women, children, and older people. So there's already quite a lot in this one standard. And I'm just going to go through how this might lead to differences in how you conduct your reviews. So the key points for our chapter in the Cochrane Handbook are to think about health equity when you formulate the question, possibly using a logic model. Secondly, plan ahead for what methods you need. Thirdly, to think about how you're going to summarize those findings in summary findings tables. And last, to interpret those findings for the readers and the users of the review. So first, when you're thinking about the logic model, we've cited this one logic model many times because it does refer to equity in the community context, which is one small bubble on the left in this diagram, the family socioeconomic status. But certainly thinking through how your intervention is supposed to work and what might be the equity issues in how it's delivered, how it's received, and the effects that it has might lead to thinking about different methods for your reviews. So that leads into the second way to think about equity in your reviews is decide what methods you need. And this includes different methods. So one method might be thinking about searching. So making sure that you're searching relevant databases beyond health, such as economics and sociological. And it might include searching different sources for gray literature. The second methods you might consider for equity is relevant study designs. So it might be relevant to go beyond randomized trials if you're thinking about implementation in different contexts. You might include interrupted time series or control before after studies or other kinds of quasi-experimental studies. And a third possible way to consider methods for equity might be to think about the process and context and whether your systematic review will assess the process of implementation in any way. And the third is to think about implications for summary findings. So this actually would start in your methods by considering whether you might conduct subgroup analyses for specific populations to separate out the findings. And this is one example of a Cochrane review led by Carla Soares-Weiser on vaccines for preventing rotavirus diarrhea. And in this review, the authors decided to present two separate tables for the summary findings, one for high-income countries and one for low-income countries. And you can see that in high-income countries, because there is less rotavirus diarrhea, the absolute numbers of children who benefit are much fewer, so 11 per thousand compared to 38 per thousand. So this is one way to think about showing how the distribution of effects is not the same in different settings or different populations. And the last point, I don't have a great example for you, but interpreting the findings of health equity in the discussion and in the implications for policy really matter for the usability of these results. And I guess the key messages going forward are really that average effects can hide distribution of effects. You need to think about equity from the beginning of the review to design the methods to address it. And the Cochrane Handbook chapter available now is a starting point, but the Cochrane and Campbell Equity Methods Group is actually working now with members of Cochrane to think about do we need further development of these tools for equity and possibly even methodologic standards for equity. So with that, I just want to say thank you and look forward to the discussion.
Thank you, Vivian. Thank you for going over the framework and the structure of the Cochrane Handbook. So I guess we can move now to the question and answers, and we are on time. So we already have 3 questions. So let's start with the first question to Professor Butta. Pfizer COVID-19 vaccine should be stored in -70 degrees Celsius. What are some initial equity concerns that immediately spring to mind?
Well, clearly, this is a vaccine which would be very difficult to roll out in circumstances where the cold chain does not permit -70 storage. There is some evidence emerging that you may not necessarily need -70, that it would be adequate even at -20. But at an early stage of the pandemic, when before WHO tied its entire bandwagon to AstraZeneca vaccine, there was the move to try and improve at least cold storage, ultra-low cold storage in some countries. And those were deployed at the level of the major cities. But I do agree This is a vaccine that would be currently very difficult to roll out in countries where the cold chain is poor, where electricity supply is variable, because these ultra-low cold storage freezers are also very much dependent upon stable electricity supply with very little backup. But, it is what it is. It's a vaccine that was developed and for storage at that level, but there are other mRNA vaccines that don't require that ultra-level low storage. So Moderna, for example, is pretty stable at -20. And there are other vaccines, particularly with inactivated viruses and with viral vectors, where storage at room temperature is possible. So we have a range of vaccines available. So everything should perhaps not be judged against the standard of the Pfizer's ultra-low storage.
Thank you. So I have a question that could go to either one of you. Is there such a thing as tokenistic equity consideration? Could this be harmful?
Vivian, I'm punting this to you.
Yeah, I can see that. That's a tricky question. I'm not sure. I think what we found in systematic reviews, especially in Cochrane and Campbell, is that there's sometimes very little evidence about equity effects. So taking an equity approach can help to, I think, surface the lack of knowledge about equity and possible equity effects. I'm not sure what the question is thinking about in tokenistic, but certainly there's some evidence that some interventions actually exacerbate and worsen inequities. Something that we've looked at in an overview of systematic reviews, that some interventions that are aimed at whole populations that don't take into account cultural or health literacy issues could actually leave people farther behind. And I think that's probably true with the case of COVID, that if we're reaching the easiest to reach, we're missing those who are worse off. But Zulfi, I'll leave it to you.
So I think it's a thoughtful question, because, the one thing that we should be very mindful of is, particularly in this day and age where various measures of inequity are put forward, whether it's Black Lives Matters, where it is diversity, equity, and looking at some of those measures, is that if you do want to bring about systemic change, then change should be meaningful and not tokenism. Just appointing a person or having a diversity officer or taking making a few appointments in the organizations just to give you a flavor does not really mean that you have addressed the fundamentals of inequities and particularly racial disparities. So it is very important that organizations do so meaningfully by changing mindsets and also ensuring that you put measures in place that really affect the fundamental impact of such disparities on those who matter. So I think the question is directed towards the ethos of the question and not just superficial measures and metrics that many organizations or groups may be able to do just to meet certain criteria and not necessarily change mindsets. So I think this is something that I particularly empathize with, that you should not be, just as many people in our scientific fields, many people now make a deliberate effort when they are publishing to ensure that you have gender representation, equal gender representation, and many a times I've seen that those are token authorships being offered just to create a certain balance in a publication. And I think that's totally wrong. If you really mean it, then you've got to involve people from the very get-go as part of the scientific enterprise as equal partners, but not necessarily, hand out gift authorships to either authors from low and middle income countries just because you want to have some names appear and look good in front of editors. So I think the question is genuine, and it's something that anybody involved in this kind of work has got to ask himself or herself.
Thank you. So we have a question from Chiara. Some reviewers, and I think this would be going to Vivian. So some reviewers might struggle with the conceptual clarity of health equity. What work has been done to improve this difficulty?
Yeah, thank you for the question, Kira. I totally agree. There's a dimension of health equity that is a judgment of what's fair. And so the Cochrane and Campbell Equity Methods Group has followed the definition of Margaret Whitehead that inequities are unfair and avoidable differences in health. And when we worked on this in developing the extension for PRISMA for equity-focused systematic reviews, we developed a framework, further developed a framework that had been published previously called Progress Plus. And I didn't include that in my presentation, but it's one way of thinking about what are the factors to consider in dimensions in determining inequities. So Progress Plus stands for P for place of residence, such as rural, urban, low, middle income country. The R stands for race, ethnicity, language, and culture. The O for occupation, the G for gender, sex, E for education, S for socioeconomic status, and another S for social capital, so the supports in a community. And the plus for other factors that are associated with discrimination and exclusion. And some of those factors include disability and age. And I think age is something we've seen very dramatically in the COVID pandemic, ageism, and also, as Sophie mentioned, greater vulnerability to severe infection and death from COVID. So I think that's the way that the Campbell and Cochrane Equity Methods Group has thought about making the concept of health equity more clear for systematic reviews, but it's still a work in progress.
Thank you, Vivian, and I have pasted the link to the Cochrane section or Cochrane Handbook section on Progress Plus. Yeah, and Zulfi, please feel free to jump in and answer these questions also. So there's an important question from Laurence. How can we overcome the problem of lack of data or group size to analyze data on specific groups in systematic reviews? So,
yeah, I think this is a great challenge. So, Zulfi, did you want to go first?
No, go ahead, Vivian, I'll join.
Okay, so actually, Professor Bhuta and I led an individual participant data meta-analysis where we actually tried to get the better sample size for specific groups using that strategy of seeking the individual participant data, but it is still a challenge. So, as I already mentioned, I think one of the great values about looking at equity in systematic reviews is understanding what we know and what we don't know. And I think one of the challenges with doing an equity-focused systematic review or looking at equity in a more universal review is deciding and prioritizing how you're going to look at equity in which population groups, because it can become a bit of a data.
Yeah, I'll supplement by saying that, this is a process in which improvements will come over time. So it's a bit like when we started using the risk of bias diagrams and or graphics in systematic reviews. Many things were of poor quality. Why? Because studies had not looked at those. But over time, because people are well aware as to how their trials or how their systematic reviews may be judged, there has been quite visible improvement in many of the other markers. So our hope is that as people begin to genuinely look at equitable measures within trials, inclusion of at-risk populations, based on sensitivity to racial patterns in a given society, inclusion of people from diverse backgrounds, also gender-related disparities, that we will begin to see these improve within the systematic reviews itself. But the important question that you're asking is, systematic reviews are compilation of primary data from studies themselves. The studies are flawed. You can't expect systematic reviews to be sorting those things out themselves. So the idea here is that if people know that their own study will be graded or regarded in a particular manner, and I'm hopeful, Vivian, over time that for every systematic review, even if it was not equity focused, that just as we have risk of bias statements, that we will have very clearly an equity score, and reviews will be measured in terms of how they looked at some of those issues in their initial trial design. And if that happens, then you will not have this issue that we had even with COVID-19 vaccinations, that some of the earlier vaccinations, notably Pfizer, was in a very homogeneous population that did not have people with non-communicable diseases, they did not have people of color. And it was only because people made them realize that the subsequent trials have gone in the direction of ensuring that from the very outset that you have the people included in studies who will eventually be using those vaccines. So the eye does not see what the mind does not know. And therefore, increasing awareness around the importance of these measures in both trial studies and systematic reviews is a journey. And we are at an early stage of that journey.
Excellent points. Thank you both. Question from Tom that has been getting lots of thumbs up. It may be difficult for a systematic review to identify the relevant equity considerations for the review. Would appropriate stakeholder engagement reduce this difficulty?
Again, I mean, I think I've tried to answer that. Absolutely, yes. But at the very outset, a systematic review, as I said, is dependent upon the trials. And if the trials are based on those kind of considerations of community engagement, of layperson's participation, patient participation, then you will overcome those because they typically will reflect the clientele. I'm very confident that at the end of this COVID-19 pandemic, the world will be much wiser to the disparities that we have. And if we are, then we will ensure that we include them in our solutions.
Yeah, I totally agree that, I mean, thinking about equity in stakeholder engagement. So how do we bring on, and Sophie and Ellie, you might have missed, but in the plenary session, Maureen Smith from the consumer group talked about stakeholder engagement, and in Cochrane as authors, as members of peer review panels. And I think that kind of public participation, and also, you know, I think as Zulfi mentioned, practitioner and policymaker, decision maker participation in defining the important questions is where we're going to start to see equity come into the question from the beginning. And I think absolutely agree, it can't be in a tokenistic way.
Yeah, so there's another question that is somehow related. What can we learn from the patient advocacy movement when considering the need for health equity in research or systematic review? So kind of asking what are things that we need to do better or start doing. Any reflections on that question?
I mean, yeah, I mean, I've answered several elements of that question already, but I think one important thing that we could bring out in this entire exercise to look at equity underpinnings, knowledge synthesis, is a better consideration of post-trial benefits, sustainability of interventions. I wish that I had done, of the large number of systematic reviews that I have done, is done an additional analysis to say, what is the systematic review saying about the availability of a particular intervention in a given population? So just doing an analysis across 20 trials or 30 trials and studies to say these people participated in a lot of this knowledge generation. Is the product of that particular research available to that particular population? And I think it would be very interesting to see how people who do so much by participating in studies eventually get very little out of it, because few of those interventions find their way into the mainstream, even though they may be evidence-based. So there are many dimensions that we need to improve upon and do better. But as I said, it's a step-by-step process. At this stage, I think the fundamental questions around why does equity matter? Why should we do it? How do we do it? Do we look at it from an angle of ethnicity, gender, poverty? I'll give you one example, Ellie. For a long time, we did not go beyond just socioeconomic gradients. For a lot of the equity literature in the last 20 years, you look at equity plots and they're mostly around the poorest quintile, then the next quintile, the next quintile, etc. And as many people have heard me and others say before, the problem with just doing that is that you don't really know where the poor are. And you can't locate them. You can't really target on that basis, because it's not necessary that the poorest person is standing right next to the next category of person. Many of these people are dispersed. So we have also improved our methods of targeting and recognizing. So moving to more geospatial configurations, location of the urban poor, etc. It is still not clear as to how that is fitting into the whole scientific research enterprise. But I hope that over time we will have measures that allow people to judge as to how a particular study had tried to bridge that gap. My own work has been largely around community health workers and how those outreach workers help bridge some divide in terms of taking the products and benefits of research to the people who matter at their doorstep in their households. But it's very difficult to combine that literature with other health system literature, which is based on facilities and other services. So as we improve our methods to look at different delivery strategies, we, I think, will learn a lot better. And one of my dreams, and I'm targeting Vivian today because I've got her in a captive mode, is to say how we can do network meta-analyses that bring various elements in relation to how service delivery was done in trials. And you can compare what strategy worked better by what category of health worker. Is it true that only things work in facility settings? Or is it possible that we could get gains with alternative strategies, including outreach workers or mixed models? Those are techniques and technologies that we need to have that will allow us to learn a lot better on how to bridge these gaps.
Yeah, thank you. So
quite the challenge, Sylvie. I mean,
that's our next collaborative project, right?
Yeah, well, I think that the network meta-analysis has this potential to look at the how you define the intervention, right, as different interventions. So I think that's what you're getting at, is the actual delivery is a different intervention, and how can you use network meta-analysis, a comparative analysis across those different interventions. I just saw a protocol yesterday for something like that, looking at social care for dementia using a network meta-analysis approach. So I think that kind of application of network meta-analysis is coming, and is quite exciting to think about equity as an outcome of that kind of analysis. So how do you look at a differential effect in a population inequities as an outcome of systematic reviews, rather than an equity focused review?
And also cost effectiveness, Vivian. I think inevitably one would have to measure not only things like, is it just possible to deliver something, but is it really efficient, and do you get gains at the end that are more meaningful if you use one strategy versus another? So it's not a different, so it's a different approach to answering a question which was not a primary question within trials. So I think some of these things can be done using systematic reviews much better than to design a mega trial with 20 arms, which is just not possible.
So let me bring in a question from Nikita, which is kind of related. Is it a mindset that needs changing, the tools and methods, or both?
I think both. Absolutely both.
What do you think
Yeah,
priority is?
I think that, well, so what I was trying to get at in my presentation is I think you have to think about equity from the beginning. So I think it's a mindset in that sense, is that in formulating a systematic review question, what are the equity considerations that drive that question? So what are the implementation concerns, or what are the possibilities for distribution of effects? That's the mindset at the beginning, how we formulate questions, and how we prioritize equity, I think, too. So Cochrane has prioritized equity, and Peter Tugwell, one of the co-conveners of the equity group, is leading an initiative within Cochrane to prioritize what are the reviews that have had enormous impact and really should be prioritized for an equity lens. So that, I think, is changing the mindset and the culture around systematic reviews to prioritize equity. But then you need the tools to do it. So I think you need both.
Thank you. So we have a question about equity and climate change. So what do you think Cochrane can do going forward to help address health equity in relation to climate change and planetary health?
So that's a great question, and I'm not sure that I have the absolute answer to this. Many of the issues that relate to climate change and its impact on health also deal with tremendous inequities, because the countries where these impacts are maximal are also low and middle income countries. If you take the example of issues of water security, agriculture, and some of the consequences, they are in the poorest of the poor. Now, that's not to say that studies need to be done in those populations, but I think one needs to be aware of this in the sense of if you are finding a particular impact in a given population that is based on a certain plausible pathway. And if that pathway is probably much worse in circumstances where climate change has made that difficult, then encouraging people to evaluate, if not the studies, but the interventions in those populations becomes a clear imperative. And I'm thinking at this point in time of populations where food insecurity has been compounded, which existed because of things like climate change and by COVID-19. So very few studies have evaluated that nexus, that combination of the two. So the answer to that question is yes. I mean, climate change is ubiquitous, and increasingly we need to have studies of what kind of solutions and interventions will make a difference. And they would then by default need to be done in populations which are generally under inequitable burden and stress. Vivian?
Yeah, I mean, I think I totally agree. So I think there are different levels of what Cochrane can do. So, I mean, I think, I've been in discussions with Denise Thompson, who is leading an initiative to develop a field. I actually haven't followed it, but a field within Cochrane focused on climate change and health. And in that sense, I think Cochrane can prioritize reviews that address issues that you mentioned, Sophie, about food security, the impact of drought and flooding in different areas. And that is actually a partnership with a new Campbell group on climate solutions, which is looking at solutions to climate change. So adaptation to climate change, how we change food production and food systems, for example. So I think there's different levels that Cochrane could work at. Yeah.
And we have the Cochrane Nutrition Group, which is increasingly keen to bring in food security and some of these elements, and those could also link to climate change and its impact on agriculture and productivity.
Yeah, and that also links across with Campbell. So I think there's a joined up effort to climate change and planetary health because it's really social and health systems. And I think applying an equity lens to those kinds of questions is also important, because the people who are affected the worst by climate change are those in vulnerable settings. So I think the more we develop and adapt the tools for looking at equity and context and systematic reviews, the better we can answer questions about health and climate change.
Yeah.
So Vivian, are there already linkages between Campbell and Cochrane regarding some of those topics like climate change or food insecurity?
In both, yes. So that's the short answer. But so with Cochrane Nutrition, myself and Betsy Christensen are on the advisory board of Cochrane Nutrition, and Campbell Nutrition is working also with Cochrane, with Zulfi Bhuta and Elizabeth Christensen as the co-chairs. And with the climate solutions, Neil Hadaway is one of the co-chairs of the Campbell Climate Solutions, and he has been working with Denise Thompson on the Cochrane plan for a field on climate and health. So I think in both areas there's an interest in working together, and the groups have been connected. Yeah.
Great, thank you. So we have about 7 minutes left. We have 3 questions, maybe 2 questions and 1 comment. So Daksha is asking whether recruiting Black, Asian, and minority ethnic groups in trials is challenging. So getting primary studies for review difficult. Do you have pointers on this, please?
So I'm not entirely sure which geography is being referred to, but in our experience, trying to recruit marginalized populations is at times indeed challenging, but it requires a lot of community negotiation and discussion, and that's why working with the community from the very outset to build that kind of confidence and that bridge is the way to start studies. So I wouldn't call this impossible. And as we have seen during the COVID-19 pandemic also, so many studies which started off by having very little recruitment across the socioeconomic ethnic gradient have ended up by being very successful at recruiting people. Once people have confidence in your motives, that you're not doing this for an ulterior motive, and that those things would benefit the communities that the studies are being done in, people will participate. But if you have parachute research, and if you come in basically with zero intention of having the fruits and benefits of your research available to the population that you're actually doing these studies on, then I'm not surprised that down the road, on study number 2 and study number 3 and 4, people will naturally turn back and say, why are we doing this? So participation in studies, particularly at population level by populations and communities, is very much dependent upon that confidence building measure. And therefore, certain ethnic groups and certain groups that are deprived will have great hesitation in participating in research because they don't quite see the benefit of doing so. So if you want to do that, I would urge very strongly that you build those bridges, you build those confidence, work with those communities, and spend that time and effort in building that confidence in the enterprise of research. And over time, they will participate. I mean, I've done enough studies in conflict settings with very difficult groups, including the Taliban, to recognize that nothing is impossible.
Yep.
Yeah, I just agree with that, but also we developed an extension for the consort, the consolidated standards for reporting trials, that included reporting the population distribution of the samples in the trials according to ethnicity and other equity factors. But we didn't really think about recruitment. And there is a researcher in Australia, Bianca Bernath, who's just leading the development of an extension for consort, focusing on diversity of recruitment and participation. So I think there will be more coming on how to, what is the evidence about recruitment strategies. And I totally agree with Zulfi that it's about legitimate participation and inclusion and sharing the benefits of the research. Yeah.
Great, thank you. How important is knowledge translation and dissemination in equity-informed reviews?
I think that goes back to stakeholder engagement in reviews at the start, but also at the end. So I think if we're thinking about knowledge translation, I think of it as knowledge translation and exchange. So I think it's very important that the findings with respect to equity are part of the knowledge translation strategy. And I think, as Zulfi already mentioned, it's one of the things we can do as systematic reviewers is shine a light on what we need to know about equity. So what does the future research need to do to improve what we know about equity? Over to you, Zulfi.
No, that's fine. You've answered it beautifully.
So, Zulfi, maybe you could address the next question. Can you suggest ways of building bridges and building confidence with hard-to-reach communities? And maybe thinking about the example you gave us with the Taliban would be helpful.
Oh, well, I mean, I think there is no cookie-cutter approach. So it depends upon the context, it depends upon the particular population and all. But I think it all starts from research prioritization. So if you want to go to a particular community and particular group and want them to participate in research, you have to start with that fundamental premise that you are going to talk to them about something which is a priority for them. And that if you do bring out areas that you would like them to participate, that you don't quite recognize or consider a priority, that you can help that discussion by making them understand as to how they are contributing to something. So I've also done studies where people have recognized that the fruits and benefits may be far in the future. And also where we cannot guarantee that they will get any benefits at all because we don't know whether the study will work or will be negative, etc. And I've, again, done plenty of negative cluster randomized trials where a big effort at the end is to go and tell the community that we tried and we did this, and unfortunately this didn't work. And therefore we don't think you should continue to take this intervention. That's a very challenging circumstance. But if you have if the community knows that you are an honest broker, that you will come back to them and tell them whatever the truth is. In my experience, I very rarely have people slam their doors on my face. It is when you come with a fly-by-night kind of an approach, is to say, I'm going to do this. Why? Because, this is important to me and this is important, but I'm, not going to invest the time and energy in building that bridge with the community. That's when you get into trouble. So my answer to this question is, it depends on the context. It depends on how long you've been engaged with the communities. But in population-based research, such as the one that I'm alluding to, there is a very important inception phase. That early phase in building the confidence, working with gatekeepers, working with opinion leaders in the community and getting a general assent that they want to participate in something is extremely important. Also extremely important is to ensure that people have the willingness to say no.
I just want to thank everyone. It was a wonderful session, and thank you for the participants. Thank you both.
Thank you.
Thank you.